The management of tracheomalacia depends on the severity of the symptoms. We often start with medical management that encompasses pulmonary clearance regimen to facilitate clearing secretions from the airway and decrease the severity and frequency of infections, for example. But sometimes that's not enough, and sometimes we need to address the structural integrity of the trachea. We have several different ways of doing that. The most common approach is the posterior tracheopexy, where we focus on attaching the back wall or the floor of the airway to the spine so that it provides stability and support. In order to do that, we have to move certain structures out of the way temporarily. For example, the thoracic duct, the recurrent laryngeal nerve, and the esophagus. This gives us all the space that we need in order to suture the back wall of the trachea onto the spine and provide the rigidity and support that it needs. Once we attach the posterior membrane of the trachea to the spine, this provides the stability that it needs such that when you exhale or try to get air out of your airway, it doesn't collapse and you can clear your secretions so much better. One of the reasons why we may want to fix the back of the trachea first is because the vast majority of the time that is the main problem. It's the posterior membrane is just too wide, too floppy. And so being able to directly address or tackle the main issue as to the reason as to why tracheomalacia exists is the key to the success of the posterior tracheopexy. Now, there's a small proportion of patients, roughly about 10%, who, in addition to having undergone a posterior tracheopexy, likely due to cartilage instability or additional malacia, may need an additional procedure, which is considered an anterior tracheopexy or aortopexy, that provides support from the front, essentially bringing the trachea and the blood vessels forward towards the sternum to distract in opposite directions from the posterior tracheopexy and provide support in a different direction. Not all patients need this, and it's unclear to predict who will and who won't need that. When we approach the airway from the front for cases that need an anterior tracheopexy, aortopexy, we need to create space as well. So this requires us to remove the thymus, which gives us that additional space that we need to bring the trachea and the blood vessels forward towards the breastbone or sternum. Whenever we're placing these tracheopexy sutures, we use a special camera inside the airway, which is called a bronchoscope. This allows us to visualize the position of these sutures to make sure they're perfectly placed to where we want them to be and allow us to create the maximum degree of improvement in the airway patency. One of the great things of having done a posterior tracheopexy before doing an anterior tracheopexy is it provides stability to the back membrane, such that now that we bring things forward, it stays in place. And so you're able to pull in two different or opposite directions and have that support from both angles. Let's talk a little bit about patients who have combined vascular ring or blood vessel related compression of the airway and how we deal with that. There are two main phases to the treatment of tracheomalacia related to blood vessel compression. The first involves the relocation, the moving, or the displacement of the blood vessel to relieve the compression created from the blood vessel. And the next one involves addressing the actual deformity or compression that this airway has as a result of that blood vessel being there for so long. That is often sometimes as simple as a few stitches, such as a tracheopexy to expand the airway, or sometimes it involves some more complicated maneuvers, such as removing a segment of the trachea or reconstructing it in a different fashion. Given that there are several different structures around the airway that interplay with the airway and the space where the airway lives, such as the esophagus, the heart, the blood vessels, the lungs, we need to have specialists from all these different disciplines involved in the planning or designing of the operation to the actual conduct of the operation. So that's kind of why we work very closely with all these multidisciplinary teams for the optimal outcome. Recovery after an operation such as a posterior tracheopexy, it depends on a couple things. First is the underlying health condition of the child, how sick they are to begin with. And next is how much we have to do to get things better. The more things we have to do, the longer the recovery will be. But in general, most patients are able to be in the hospital for roughly about a week. Some need less, some need more. There's no rush. We take our time and do it well. We've treated hundreds of patients with tracheomalacia over the past several years. Specifically, for posterior tracheopexy, we've treated up to 700 patients and counting since we started doing this in the early 2010s. Each patient is very different, and we continue to innovate And the technique we had at the beginning is not the same we have now. And we've continued to evolve and perfect this technique that has a great potential to improve the quality of life of patients with tracheomalacia. The impact of a posterior tracheopexy with patients who have tracheomalacia can be profound. We've had great success with stories such as ability to play sports that they couldn't play before, go back to school, have less sick days, simply eat better, breathe better, sleep better, and simply be a healthier kid.